All right, it looks like you're on.
All right, good afternoon, and we apologize for the 10-minute delay, but because we own the channel, so we can start a little bit late, I guess. Well, that's not the case, but just so that we know that these are our casual events, and we try our best to be on time, and we had some prep issues, and we have actually a couple of guests today. So we are gonna have a lot of discussions around the healthcare issues, updates from COVID-19, and just so that we have a proper start. My name is Kemal Erkan. I'm the chairman of United Medical ACO. Other than accountable care, we are also a turnkey healthcare service provider for nationwide in United States. And I'm gonna have a couple of my employees today, my team members who are gonna be participating with me. We'll have a lot of good discussions. So Tanner Fuchs from our business development is always helping us with these events. But today I also have Christian Scott. He's here while he's doing his master's, and he works with me on the clinical data, and he does a lot of risk adjustments and clinical integration related issues between the payers and our offices. So he's going to join me later on. And we are going to have Muriel Campos, one of our senior client managers. And each of these events, we are going to discuss one part of our practice management system, one module. And today, it's going to be the collection module that we are going to discuss. So Tanner, if you would like to introduce yourself, please.
All right. Yeah, thanks, Kemal. My name is, as Kemal mentioned, Tanner Fuchs. I'm a member of the business development team here at United Medical. Been with United Medical just under 2 years and serving a capacity to help support our clients when it comes to workflows training, and developing their relationships with their payers and helping maintain their day-to-day. So I'm excited to be here on for our event today, and we got a lot of good topics today, as Kemal mentioned.
All right, so I'm going to actually just go to the live data from Rollout. So let's just start with that. Okay, so as you know by now, we are actually looking at our numbers on a regular basis every day. So this site actually we used because it does really help a lot for us to see what's happening for the last couple of days. And the really important part of this is that when you look at the 2 days ago, you can see confirmed new cases. And then you can see the yesterday's numbers as at 67,000. And this, it also gives us the today's numbers, but obviously it's 12 noon here, so we have a long day to go. But what we understand from here is 67,000 and 65,000 in the last couple of days is the norm for today, for these days, which is extremely high, but we got used to it. That's kind of the part of the problem. So if you're a telemarketer and if you're calling me right now while I'm doing a live session, good luck to you, because we'll never buy anything from you. So, but if you subscribe to the channel and then watch the live session, I promise you I'll pick up the phone later on. But clearly, you have to really see what your prospect client's doing. That loser who's calling is not going to have any chance. So now, while we have this, let's just give you the Delaware update while we're here. And I will also do that from the live side. Delaware. So we have been managing this much better in Delaware, not because we are doing anything extraordinary, but I think we are able to have good accountable care organizations in place, and we were able to keep our patients out of the really expensive hospital settings, and then we were able to keep them at home while they were actually going through this. And I'm highlighting the keeping them out of the hospital because, as we'll discuss later on today, hospitals are even more hungrier now because now they want to actually not only not being able to manage their inpatient settings, but they want to get into our outpatient settings. And then I'm going to actually talk about those with Tanner and Christian. So what you see here is the current hospitalization. So this means number of people with the average 14 days, total number of people who were hospitalized currently, and then new hospital admissions, anyone who's admitted on those days. That number is maybe last 3 days is low, but still 35. As you can see here, that number is going up. There's this little curve here. So percent of positives, percent of persons positive, and then by clicking here, you can see the percent of tests that are positive. Those are two different things. A lot of confusions in the beginning that was there. But if you look at the persons testing positive, we are looking at 25%. So 10 or 25% is 1 out of 4 people is positive. So if you test more people, perhaps more people, like to 25% is not going to increase, but what's going to increase is this number. So 339 people positive because there's so many tests done. If you do twice more testing, 25% would stay same, but 339 is going to go to 680. So when we have these issues, then obviously we have to be smart while we are looking at these. I do want to mention the percent of tests that are positive, which is because we look at the person testing. So this is still about 6%. Which the comfortable number for us at some point was less than 4%. And then now that's not so comfortable from that point. Now, from United States and from Delaware, those are our updates from the real data. So I'm going to go back to our PowerPoint. And Tanner and I, we're going to give you some of the vaccine updates. And then we are going to have the RCM, SPM, RCM collection module, and how we actually process it by utilizing our system, and the healthcare cost, hospital antitrust issue. Now, I labeled that very carefully so that it's understood that we know every element of healthcare system is extremely important. But what's seen on the surface is not what's happening. So where we spend the money, how much we spend, who's getting paid, I want our public to know this clearly from us so then you understand why we feel the way we do. Now, before we get into all those, let's see how we are doing with vaccination, and then we'll continue after.
Sure. So as we are keeping track of our vaccine updates, particularly taking an interest in the administration rates of vaccine, wanted to take a look and see where we're at in our latest numbers for the actual vaccination rate in the United States. So after our last session, we started to notice that the numbers were starting to tread above that 3 million doses per day mark. And continuing to go up. We saw that week, as you can kind of see here on the graph, those large spikes are certain days that had larger turnout or administration of vaccines. So we had a couple weeks where we were seeing that get to the 4 million a day mark. We're starting to see a little bit of a downtrend, as you can see, kind of tailing off here towards the right side of our graph in the amount that are being administered per day. This could be to a number of different things. Due to possibly the issues with the Johnson & Johnson pause, that's certainly going to take that number down slightly, as that was a new vaccine that was being used in the administration in the fight against the vaccine. So we're still currently on pace to do 75% of the population or get towards that herd immunity mark in just about 3 months.
So Tanner, that product that we are reporting, what was the really important issue happened during that time? Why do we have, what do you think?
The dip. I do think it's due to the pause in the Johnson & Johnson vaccine. That was definitely going to, as we mentioned, with logistical issues in mind, a one-shot dose was really going to be an effective tool in getting more doses administered and more people vaccinated in as quick amount of time as possible. So that does line up with just about when we were starting to see that in the news, unfortunately.
No, you're absolutely right. I think the news that came from J&J, and I do believe that it was an unfair timing, unfair treatment to J&J. But what's happening is while these companies are competing, they are actually, their decisions have consequences on public. So now, as soon as something like that happens, people stop getting vaccination.
Correct. It doesn't just affect the Johnson & Johnson rollout at this point. It affects the vaccine rollout as a whole, and really the trust in the vaccine.
And then how are we doing in Delaware so far?
So in Delaware, we're also seeing a slight downtick in administered per day on that rolling average. This could be very much due to the same issue, although I'm not sure off the top of my head the number of Johnson & Johnson vaccines that have been allocated to the state. But as you just rightly mentioned, we might just be seeing a downward trend in the Pfizer and Moderna vaccines as well, due to the bad news or news coverage rather that was coming out over the Johnson & Johnson testing. So we're seeing a little bit of a dip here, but currently, as it relates to the rate at which we're moving towards 75% of the population being covered, Delaware's slightly above average when it comes to the national average. So here in the state of Delaware, it'll take about another 2 months to get to the 75% threshold. So we could start to see some herd immunity towards the middle or end of summer here in the state. Of course, with that being said, as long as we continue at these rates. So this is also something that we took a look at a few weeks ago. As we start to vaccinate more and more percent of the population, now we're closing in on roughly that 30% mark for the being fully vaccinated. And you can see here, it does say about 40% of the population has been at least one. So we're seeing this in comparison to the 7-day average of new cases per million. And that is, we saw it started to go up a little bit, and we had this conversation a few weeks ago on why that might be. We are starting to see it turn down again, whether this be just because there are more and more vaccines that have been administered since those conversations a few weeks ago, or it could be actually optimistically thinking that could have been our spike that we were seeing after the spring break period. If that would be the case, then that's going to be really good news, because if we were able to contain the spike in new cases to that little blip in the data with the vaccination effort, then looking forward, that could be encouraging.
So as we were discussing about the J&J, today actually we are expecting that lift to be happening. This is coming from the decision of the pause is coming from 0.0086%. So this is not 1, this is not 0.1, this is 0.008.
Right, and I think it's important. That is the percentage of cases in which we saw these issues. It's not that move the decimal place and you get to 0.8%. It is a very small percent of the cases with the Johnson & Johnson vaccine. And as they are starting to test more, part of the pause was to look into more data and see if there were more issues surrounding that vaccine. And they have come back and said there's been very little or limited evidence that there are more and more cases of the clotting issue with the vaccine. So this is just a side-by-side to kind of compare all the vaccines that are out in play right now. So with something we are updating and keeping an eye on regularly. Notice that the Johnson & Johnson is still paused, as Kemal mentioned. We're hoping to see that might be lifted as early as today. And the AstraZeneca, we're keeping track of it as it is something that's being rolled out in nations across the world. Although we would like to mention it's not approved here in the United States. So that's notated there. So with the other vaccines, not too much of an update.
So now we are going to ask Muriel to join us. So Muriel actually has done this already twice, right, Muriel?
I want to say at least twice.
Yeah. So I remember one in 2020 and then one a couple of weeks ago. So thank you for joining us again. So our goal for the next couple of weeks, take the SPM, we say SPM, and if you can just elaborate those when you start, different modules of SPM and how we are utilizing, and we are the only one in the country who are authorized to sell SPM. SPM is a practice management software through Cerner, via Cerner. So we have a partnership with Cerner. And it's important for our client and prospect clients to kind of understand how we are utilizing it. And I'm hoping that it can be beneficial for those individuals, those practices. So, Muriel, I'm going to ask you to start.
Okay. Thank you, Kemal. So as Kemal mentioned, I would like to briefly go over the collections module in SPM. It's a tool that SPM has that helps the practices categorize the patient balances into different categories. So the reason for that is because it also helps with the revenue and the collections. So I would first like to just talk about a few of the main functions that we use, and then just elaborate a little bit more on that. Kemal, if you would like to go to one of the slides. So this area, this aging area, is part of the collections module, the collections maintenance we call. As you can see, there are different parameters that are used to determine at what step does a patient balance enter a different aging category. And depending on the aging category for that patient balance, then the system determines whether it goes to the final collection step or a pre-collections process. So this is just an example. I created this little snippet as just an example of some of the parameters that we have across the board for our UMACO clients. And basically what non-collections means is the balance is not going to go into any kind of collection step as long as there is a sufficient payment, or if there's an insufficient payment or no payment. Whenever it says non-collections in each of these areas, it means it will not go into a collection step. Collections just means basically that at that point, depending on the category, then the patient account will show up on the collections report. And then I can go into a little bit more detail as to what sufficient payment and insufficient payment means. So this next slide, it represents the payment details. And this is what determines what a sufficient payment is or what an insufficient payment is. So in this case, just for an example, let's say the patient's balance is $50. Depending on these parameters, the patient needs to make at least 25% of that $50 payment in order to be considered a sufficient payment. If they make anything less than that, then that would be considered insufficient payment. And this is where the aging parameters of the aging categories come into place as well. For the next example, let's say, for example, the patient's balance is $200. Based on these parameters, the patient would need to pay at least 20% of their balance to be considered a sufficient payment. As long as the system considers it a sufficient payment, they will not go into the next collections process. Kemal, if you would like to go to the next slide.
I was just going to say we are able to actually set these up based on how our clients want. However, we do provide some standardization so that there is a proper way of using this, so it's not varying from, you have about 120 clients.
Correct.
So those numbers, so then those clients don't have to make decisions, so we can actually guide them with those decisions. So that's kind of like what I wanted to say.
Exactly. And then these parameters we have set up across the board for our UMACO providers. Now, this next little slide, I just wanted to showcase part of the collections module, which we call the collections mapping utility. Basically, what this process does is it categorizes the balance into whether they're going to go into the collections list or not. So again, this is just an example of the standard that we have for our UMACO clients, the providers. Basically what this means is the balances that are 121 days and older, they will be transferred over to the final approval list, which means they will be transferred over to the collections list. And as Kemal mentioned, of course, each client can have some kind of feedback on what they would like in terms of these different mapping definitions. However, we do have a set process for our UMACO providers just to make the workflow easier for them, to help them determine which patients they would like to proceed with collections or not.
So, Muriel, this is one part of the SPM module. So then once we take the client, once we process this, we work with a collection agency because we do not actually do that service. So that's someone that we work with. And if you don't mind just mentioning that company.
Yep, so the majority of our, or all actually, I should say, of our UMACO providers that participate with the collections process, we use Waterfall Revenue Group as the collection agency. And they're the ones that actually work the patient accounts that are approved from the client. They send out notifications, they do the calls to the patients, and try to get them to pay their balances. But we also do work with several other agencies across the board nationwide. But our main one for our UMACO providers is Waterfall Revenue Group.
All right, so thank you, Muriel. So next week, I believe Carlos is going to join us. And then after that, it's Besta and it's Reach later on. So we are going to take different modules and explain these and how our clients are using it. And also, it's probably helpful for our patients to understand what the process is. We don't want anyone in collection. We try to help them as much as possible. As long as there's an effort to make payments, our recommendations to our clients is not to go through the collection process.
Exactly.
But of course, there are times where they can't do much. So, and then there has to be an effort because we also need to respect and value the time that our physicians are doing with their practices. So this is part of that process. And Muriel, thank you again for joining us.
No problem. Thank you for having me, Kemal.
Of course, anytime. Thank you.
Thank you.
All right. So now I have, guys, I'm just kidding, but I have two sidekicks today. So I have Tanner and I have Christian. I'm going to ask them to join me, and we are going to try to elaborate some issues for you so that you can understand why this guy would be me. Why is he always upset with something, with the hospitals or with the government, who is in some cases not really understanding the issue and not promoting the right people? Now you are going to, of course, I can hear some people saying that, well, you're a businessman, of course you want to make money. Well, it's not that simple. So we are in business and we want to be able to have a fair competition with anyone, and we have been doing that. And I am not going to be humble about what I'm about to tell you today. Is that if there are this many private practices in the state of Delaware, that's because of me and my team's effort with me to keep them financially viable, so that they're not swollen by these hospital systems. Now, why I'm saying this is because we have limited resources, and then the hospitals are a little bit different. So if I just need to do one little change on the PowerPoint, and I'm gonna start, because you need to see what we are about to talk about. So now, while I'm doing this, so Christian, you do a lot of stuff with me, but you are kind of behind the scene guy, and then we ask him to come out from his where he's hiding. So tell us who you are and then what you do at United, and then I'll start the conversation after that.
Perfect. Yeah. So good afternoon, everybody. My name is Christian. As Kemal said earlier, I assist him in various ways. Could be in the clinical integration areas or data analysis, protecting the cost and risk. And recently, we have been really delving into the effects of cost and risk with insurance companies, with practices, and really figuring out how and what trends are, so we can identify how to take care of our patients better, and also be viable businesses as well, just as Kemal said. So,
when Christian started, he did his internship a couple of years ago, and then he came back for 1 year. He's after he's done, he has another commitment. But why I'm actually talking about this is because when I train our new resources, when they work with me, training is not limited with just explaining what the work is. Unfortunately, the training is also includes the real picture of what we deal with day to day, behind the scene issues, many things that public doesn't know, and therefore when we are training someone, when they're helping us, Christian, in the short amount of time, I got so much out of him. He helped greatly to understand what we are doing. So, and therefore, I am grateful for what he has done. But I also want to explain this by having this conversation with them, how we are actually dealing with these issues. So what I would like to do is just show you this slide first. So then we start with that. So what I'm looking at here is, when Tanner and we sit down and said, okay, Tanner, we need to explain this so then everyone understands what we are talking about. Well, that's never easy. You have to keep it simple. That's never easy. So here's the simplest way of a hospital. So when we say hospital, what we actually, the perception of hospital is, it's a nonprofit, it's a large employer, and it's a prospect client for so-called insurance companies at TPA. Now, this may get a little bit confusing for you guys, right? And this is nonprofit. So, Tanner, what does nonprofit stand for here?
Nonprofit should be that they're not bringing in a profit for their cost to service.
So that's really nice.
In simple terms, right?
It's nice. You're correct. What we describe here is, so nonprofit, largest employer in the state of Delaware, and prospect client for so-called insurance company, TPA. So this is CCHS. So because they're nonprofit and they are publicly, they have public duties, so we are able to, everything that we are sharing with you is available for public. So nothing is only in my privilege, it's not. So I'm just getting all of my information from public.
Mm-hmm.
CCHS is a nonprofit, right? So average 3 years, in the last 3 years, their profit is about 160 to 180 million. So it's not profit. Let's take that out. Now, as the largest employer, by utilizing their nonprofit advantage, when they are nonprofit, one of the big benefits, and anyone can correct me if I'm wrong, but certain taxes are being waived because they're nonprofits. Well, when your CEO makes $2 million, what taxes you are not able to pay? So this nonprofit acute hospital, the Saint, is with the CEO, $2 million salary. The former CEO is on a 5-year payment plan, like not payment plan, the retirement or whatever it is. Not
right. Extended contract, essentially.
It's 1.2 million to 2.3 million average every year in the last 5 years. Former CEO, who's paying this, right? You and Christian and I, in different portions, we are paying for this. Okay. Now, largest employer gives you a really big advantage, guys. So, largest employer actually means you have a lot of other vendors who have to suck up to you because you are the largest. So someone who's going to deal with your insurance for your employees, you are the hospital and your employees need to get insurance. So you are going to outsource this to someone. Who's that going to be? A TPA. Now, Tanner, the TPA it stands for what?
That's actually a question I had for you. So when we got into discussing the insurances, so in this case, we have so-called insurance. We know that it's insurance in this sense isn't for what most people would think of it, correct? They're involved with this TPA service through the insurance company. So it's coming from employer-based, or an employer's maintaining a certain health plan, if I'm not mistaken.
So the self-funded employers, like if you are as large as this nonprofit, non-hospital, so you are able to do self-funded because it's going to be less expensive for the employer. But then for processing insurance claims, for accessing to the provider network, then you need to work with an insurance company for the TPA under the term of TPA. So let's say this got a little bit dirty here. So let's just clean this up. So now TPA is a third-party administrator. And in this case, it is an insurance company. That's where it gets confusing. Insurance company was a TPA. TPA was an insurance company who looks at this large hospital and then they're like, whoa, it's my client. So there's a benefit one way. But then, well, the hospital needs me for the network. But then this balance between this and this has to be like so clearly monitored so that we are not crossing the line. So what I mean by, guys, crossing the line there is this is where the antitrust issue comes in. So what we know with the hospital systems, they are expensive. I own a surgery center. So like I own a mini hospital, just the surgical setting. And this hospital that we own gets one gallbladder procedure, $2,000. And the same gallbladder with the same surgeons, when it's done at the hospital, it's $12,000 average. And this is just for Medicare. And because it's Medicare, then we are able to discuss these numbers openly. Now, what I would like to take you from here, let's just open this TPA business, because one of my biggest lessons in the healthcare industry was in 2012. I felt so stupid when that happened, and I'm going to tell you what that is. So, and I'm going to say this openly. I did not know what TPA was for the healthcare industry until year 2012. Well, see, when is an insurance company not an insurance company? Well, it's like, oh, like, is this guy like his second language English and he doesn't know what he's talking about? No, of course, just take it easy. That's not the case. We are just educating our public here. So this is an insurance company. Under the label of insurance company, they do TPA business. Well, it's legal. TPA business, well, this arrow did work in the wrong way. The TPA business is a third-party administrator. So when you're an insurance company, Christian, how you make the money for the insurance company? And I apologize for these questions because we didn't actually discuss and rehearse who's going to get the questions, so I don't want them to stress out. So, but how the insurance company makes their income is by selling insurance premium policies. So then they are risking something. So there's a risk involved. But when they are a TPA, they are providing service for employer, self-funded employers. So this is self-funded employers. And they process claims for them. How do you make money what's the difference between here, how you make your money versus here? It's you charge certain fee, monthly base fee per person, and then you charge a percentage to the total expense of this employer. So if your income is based on charging someone's expense, your goal is to keep that expense high, right? Clearly. So, but on the insurance side, it's not the case. So the difference, why we have a problem with this one is 75% of that is TPA. So when we make this so clear, now there are certain questions. So who's TPA, who's insurance? Well, in the state of Delaware, there's Highmark. 78%, let's use the 75 to 78% range, TPA, and a small part of their business is on the insurance risk group. Aetna, same. Aetna's biggest client is state of Delaware. Mm-hmm. So Christian lives in Maryland, and he may not know Delaware. So, well, this little state of Delaware has more than 100,000 people on their plan through the state of Delaware because there are retirees, there are so many employees. So that's the biggest customer. Mm-hmm. Aetna also has the contract with Christiana Hospital. They are their TPA. So now, why are we actually, all of a sudden, what happened to Kemal? Why is he really talking about all this? When I saw this news, and it was it just happened that I didn't know it was happening. It was last minute. So hospital, RCCHS, is getting in bed with Highmark, the insurance company / TPA 75%. And then then I actually did tweet this, and I really want people to go and read them. If you work for United Medical, you definitely need to read them. If you are a client or if you are a patient of United Medical, please look into it because we want you to know what's happening. You are paying the taxes for these. So we see this vertical relationship. And then why is it important? Is because this really hospital, we used to call them 800-pound gorilla, but I think they are now 1,200 pounds because they are getting fatter every day. This is for Christiana Hospital. Everyone in Delaware would call them the 800-pound gorilla. Well, maybe they should get a bariatric surgery. I don't know. But the problem here is where we spend the most is, and we are the number one in the world for the highest expense is in healthcare. And then that's the big part of it is the hospitals. And big part of it is the insurance companies because they keep the prices high. So this is available to everyone. It's on my Twitter account. You can see the link. 1,800% profit margin. Well, it's like Christian, if you buy something for $1 and sell it for what, $1,800? Is that what it's about, right?
Mm-hmm. Right.
It's good money. So now next week, I'm going to actually show you Christiana Hospital's tax returns, and I will just look into their last 5-year tax returns. It's also publicly available, and then where they actually make money. For example, from lab-related services, they make 100% profit. So if you get urine analysis, it's 100%. So surgical stuff, it's really at 60%, I believe, and every year it's increasing. Now, this is where we ask Christian, because one of the things that I don't know if let me just see if, okay, so what really kind of increased my blood pressure is, I do have a good relationship with her. When we need something, she would at least answer her text message. She wouldn't take any action, God forbid, but she would at least answer the text. So she says, Dr. Nevin says, we are going to do a new transferable model that's bringing blah, blah, and then reinvent the chronic care world of the healthcare. Well, first of all, please stay out of it, CCHS or any hospitals. You provide services for non-emergency services in your emergency setting. Non-emergency services in your emergency setting. Even, even young Christian got old in the last 6 months because when he sees these nonsense, he's like, why is this happening? I'm like, well, I mean, I wasn't born here, so you were born here. Maybe you can help us to understand this better, right? So this is happening, guys. So let's actually elaborate this a little bit with some patient examples. So, and then the spend, like where the spend is happening. So let's see. This is the real data. We are not going to mention the insurance company here. Real insurance population. And if Christian can elaborate this for us.
Of course, yeah, I'd love to. So what we see on the left-hand side, the leftmost column, is the number of patients. And you see in this population, in total, there's 77,578. And these are all patients above 18. That's another important distinction here. And then we look at the cost numbers also next to these patient numbers. So for the 7,500 patients, they account for $36 million approximately of cost in a year. And that cost can come from visiting doctor's offices, surgeries, going to hospitals, getting prescriptions, etc. And we see that 64 patients account for $12,300,000 of cost. And so when you look at these percentages, literally 64 of the 7,578 patients account for 25% of the cost in this patient population. And so when you see these kinds of numbers, you have to ask yourself, why is this happening? Like what is the trend? What can we see here? What questions can we answer? And I went through actually these numbers yesterday and today, the 64 patients. And one thing that I found was many of those patients are visiting hospitals. That's one of the number one cost increasers of these patients. And so obviously that's a huge problem. Not saying that there aren't reasons to be at a hospital, but when we delve into why this could be happening, there could be a number of different reasons. So for example, often when patients come across issues, one of their first thoughts is to go to a hospital. But as Kemal says in one of his articles they wrote 2,000 years ago, and he mentioned that earlier today, you could get a gallbladder surgery and the cost for Medicare is $2,000. You could get that same surgery at a hospital for $12,000. So let me say that again. So $2,000 for Medicare at a surgery center, or $12,000 at a hospital for the exact same surgery. And when patients don't know these distinctions or that these relationships exist, they might just go to a hospital. And some patients might even ask, why is this important? And we would say, because it increases your insurance premiums in the end.
So, and that's excellent, actually. And again, it's really important for you guys to know that we don't have time to rehearse any of these, so we don't know how it's going to come out. And when I'm listening to him, I'm so proud of what we have done. And I'm so also proud that he's able to elaborate this at the level that he just did. So what I would like to share also is what are we looking at here is, Christian, so this is one of the insurance companies, right? Again, so this is just one, one insurance company population that we deal with. So these bars, each of them there's a patient associated with them. And then this is the number of times in the last 12 months they go to the ED. So this person I know very well, name, and this person I know very well, we haven't seen these people for 17 months. Now, I said when I know them very well because they show up on our reports all the time. Now, let me actually just show you why they go to the hospital as an example. So they go to the hospital for these non-emergencies. So this patient wants to get med refill, shortness of breath, asthma. Oh, I ran out of my medication. And there's so many others here. Now, I know she will be watching this at some point if she's not watching it live. And I want other hospital CEOs to watch this and insurance companies to watch this. But mainly, I want our governor and our health care committees in the state to understand why we say what we say. Now, when the patient goes to the ED, 36 times in 3 months. Like one of them was actually, it was the second to the last. It was happening in 3 months. Because in the 12 months, it was 50, I believe, for him. So this patient goes to the ED, to Christiana ED, let's be specific. And then she's not able to tell her staff, when the patient comes for non-emergency, please ask them to go. Christiana also has a family medicine residency, therefore they have an office. Mm-hmm. Well, okay, so you are here and then you can refuse the patient, no problem, but they're not in the emergency situation. So let's just transfer you to the family clinic. Mm. You do that, Dr. Nevin? You don't need to tell me how to do the chronic care management because you don't know how to do that. Your business is hospital. Your business is not prevention. You deal with the other side of this. So you don't deal with the prevention. In fact, when prevention happens, it hurts your income. So if you can just charge a little bit less, okay? So then we would be able to, control this. Now, Christian actually explained, this is the real data, right? So this is like anyone with some, like I'm talking to, how our president likes to have a beer with the average Joe. So I'm talking to the average Joe, okay? When you have this, 64 divided by 7,500 is 0.08%, so a little shy of 1%. So we spent 25% of the expenses for that group, guys. So, Dr. Nevin, we don't have a healthcare crisis. We have a hospital crisis. And you are leading that crisis. You are the head of that crisis. You are the head of that trouble because you charge a great amount of money and you mark up your services at a level where you can build those most expensive granite buildings that means nothing. Like, Christian, I'll tell you something. One of my really close friends, won't mention the name, but my people would know who he is. And his wife, they're out of state. We had to go to Johns Hopkins. This is year 2016, if I'm not not 2016, 2014, and then 4 years, 2000, maybe 11. So this was the old campus of Johns Hopkins. What do we know Johns Hopkins from the children's standpoint? They are one of the best hospitals in the world. Mm-hmm. Okay. So I drove down from here, him and his wife and our little baby. And they have the money, they can buy the hospital. But at that point, when they were having that type of issue, it didn't matter. So because Johns Hopkins says, well, we'll take care of you, whatever we can do. That day we stay in the hospital, 4 patients with their parents, they were sharing that unit. Guess what? There is no problem with the outcome because they were the best, one of the best, or top 5 in the world, being the Children's Hospital. So when you build private, patient rooms, it does not increase the quality of the outcome. That's a big lie. That's a big lie. So 64 people out of 7,600, less than 1% is 25% of the cost expense. Where that's being spent? Well, you need to ask that to Dr. Nevin. So we have a bariatric Friday event, which is supposed to be starting in a minute. We are going to actually elaborate this even more. We are going to come back to you guys with more examples. We are going to go after this. So I'm calling the Attorney General's office because also this merger, when your biggest healthcare company is merging with your biggest hospital, that's not gonna help anyone. So let's be smart and then let's be accountable for what we do and let's go after these issues. Let's share these with other people so then they understand why the struggle that we have to go through, what we are fighting, because it helps us when we know our patients know what we are going through and our providers know. So it makes us stronger when we are able to share this and know that this is understood by other people. So Muriel, Christian, thank you for joining us. Tanner, thank you for helping me with the presentation. We'll be back same time next week, and we'll discuss this more in detail. Thank you so much again. We'll be back on the bariatric event in a couple of minutes. Bye-bye.